So 4 years old, presenting symptoms, swelling in her face, notably in the morning, worsen throughout the day, puffiness in the leg and abdomen, reduced appetite, urine looks frothy and unusual color, no fever, no diarrhea, no trauma. Okay lah. Then the examination, BP 100/60, weight 15 kilos, but slightly increased over the past 2 weeks. Height about 95 cm. Examination, moderate edema, mainly on the face, on the leg and abdomen. Urine check for protein 4+ on the dipstick, normal urine output. So, spot diagnosis. Nephrotic syndrome. Okay, so I'll ask all the basic question lah, so even houseman can answer. So pathophysiology in children, what are the typical cause in nephrotic syndrome in children? Minimal change disease lah. Yeah, okay. Secondary causes?
Can be autoimmune.
Okay.
SLE.
Okay.
Or some other secondary causes like glomerulonephritis.
Yeah. Most common glomerulonephritis in children is what?
Post-strap.
Post-strap. Okay. Alright. Other condition?
Other condition.
One more?
Focal segmental.
Okay, that one still part of glomerulonephritis. Other systemic condition that can cause nephrotic syndrome in children?
Some IgA nephropathy.
Can. What else? Ada common problems in children? Common children punya masalah. Rashes that can also affect kidney.
HSP lah.
HSP as well. Secondary causes due to some other diseases. Apa lagi? If uncontrolled.
If uncontrolled. Uncontrolled.
We have so many here.
Uncontrolled.
Uncontrolled diabetes lah. Ayah. Okay. Alright. So, okay. So if minimal change disease, if you do the renal biopsy, what do you see? Nothing on the normal microscope, but you see on the electron microscope, what do you see?
The basement membrane will be thickened.
Not really. Loss of podocytes. Okay. Alright. So that's typical minimal change disease lah. Okay. So you mentioned about focal segmental glomerulosclerosis. If this child has nephrotic syndrome due to FSGS, what are the clinical nephrotic syndrome going to be like? Is it?
Here have hematuria, microscopy, and also have a deranged renal profile, and likely will have hypertension as well.
Okay, so some atypical features lah. If you start steroid, what do you expect the response going to be like?
Will hard to achieve remission, likely won't lah.
So, what you call the term?
Steroid
most likely they are the steroid resistant nephrotic syndrome lah, because minimal change, most of the response going to be steroid sensitive nephrotic syndrome. Okay. Alright. Also, if SLE as secondary causes, what are the features?
Other clinical features, alopecia, oral ulcer, mild rashes, joint pain.
Alright. So on top of it, as you mentioned earlier lah, the hypertension, then the nephrotic range sometimes can be nephrotic range sometimes, have hypertension also. Okay, post-strap and diabetic nephropathy, I think same also lah. Okay, so I give you scenario where patient first time diagnosed as nephrotic syndrome, confirmed by urine PCI. How much urine PCI? Usually the range to say nephrotic.
Urine PCI.
More than berapa? So to diagnose nephrotic syndrome, what are the 4 criteria?
Proteinuria.
More than berapa? How much?
Persistently for 3
Okay,
days.
but that one is from lipstick.
Lipstick, yeah. Right.
So calculative one berapa? Exact numbers.
Calculative one.
Yeah, you send the urine PCI berapa number? If you send 24 hours berapa number? But we don't really send 24 hours nowadays lah.
Correct.
Hmm.
Yeah.
Kau susah nak dapatkan 24 hours. This one should be on the tip of your head already, because it's bread and butter pediatrics. So bread and butter pediatrics, we have to ask in detail, very very detail to the point until berapa level lah. Okay lah, because you MO already mah. Kalau you medical student or houseman, I wouldn't lah, but still I expect them to know. So okay, but for you lagi lah.
Yeah.
Berapa? So you
25.
no, sorry.
25.
No lah, 200 lah. More than 200 millimole per liter or something like the unit for urine PCR. It depends on the unit. Some unit is a bit different lah. Okay. Alright. Okay, so ada proteinuria range of proteinuria. Some proteinuria not even proteinuric. So sometimes tak fulfill diagnosis of nephrotic syndrome lah. Sebab dia punya maybe bacaan maybe 100 over sahaja. For example, so you have to think about some other secondary causes juga lah of leaking. Okay, and then of course ada hypoalbuminemia. Berapa now we take the albumin level?
25.
No, 25 the old definition.
20, yeah.
No, 30. 30 is the latest one, latest guideline. 30. Okay, 25 is the old one. I think if you see, I think they gonna release the new PITS protocol code, then probably they update to 30 already lah. Okay, alright. So what else? Hypoalbumin dah. Second, third one. Of course ada generalized edema anasaka tu, of course ada. Alright. Apa lagi? Last one. Satu lagi. Investigation apa we send during the initial phase? We want to check what?
The cholesterol.
Yeah, cholesterol level lah. But that one is just part of the diagnosis lah. But the most important thing is always the proteinuria range of proteinuria. Itulah how you prove it. Urine PCI, early morning urine PCI lah. It's easiest because you can send morning, petang dapat result already.
Yeah.
Okay. Alright. Okay, so I give you scenario. So you already prove patient have nephrotic syndrome based on the those criteria. Then when you start the treatment, you give your steroid. Okay lah. I'm not going to ask you the details in terms of dosing. You should know already. But I'm going to give you a bit more scenario that is a common real scenario. Patient had 40 day 7 induction. By the 8, patient had cough, runny nose. But somehow the urine protein from 2+, 1+, they go back up to 2+, 3+. Okay. So you treat the infection, but not continue the steroid. Then by day 20, still like 2+, not really going into remission. Okay, so had another infection by day 24, go back to 3+, 4+. So in the end, by day 26, 27 already, you have to start thinking, is one steroid resistant or steroid? Or late responder, steroid resistant nephrotic syndrome. So if this kind of scenario, what can you do? You tak ada of course you can consult nephrologist lah, but I want to get your thoughts on it first lah. What are the possible explanation? What are the possible plan you can do?
Because of the URTI, probably will have breakthrough proteinuria and
okay, alright.
So probably we can reinduce again with the proper duration.
Okay. But the patient has been on high dose steroid, the 60 mg PKOD from day one itself. You will encounter this kind of patient from time to time. But even with that, some of them is they respond lah, but some of them they don't respond. Okay. So what can you do? You want to restart back the whole thing? No, not really lah. We don't really do that induction back. We don't really count it as a day one. Okay. What other possible management can you do? Can you extend it to another further 2 weeks?
Extend it.
From day 28 to become another 2 weeks, day 40. Up to day 42. Okay, if they respond,
then consider responding.
So can consider a responder, but the term become late responder lah. Okay, that's why just another term lah, late responder. And probably out of 90%, they are responder. Another 5% probably late responder. Another 5% probably the steroid resistance type lah. Okay. Of course, by day 28 too, if you still unable to achieve remission, you should consult already nephrologist. Some nephrologists will extend another 2 weeks because of this recurring infection or not. Some will try give IV. Yes, they will give the IV metaprep lah. There is the regime lah. There is the regime. They give it over 3 days, something like that. Okay, so they will send the baseline proteinuria, range urine PCI. They give the metaprep over 3 days. Then they will repeat the urine PCI after 3 days lah.
Then respond.
If they respond to metaprep, if they are responder lah based on the urine PCI bacaan tu, mean they should become normal or non-proteinuric range at all lah. Okay, because whatever you give for those 28 days too, they kind of like package it into 3 days.
Condense it.
Yeah, because of this recurring infection and whatnot. So they probably can like do that also. Okay, so 3 days like that lah. So okay lah. Okay, so if patient still tak respond after you give metaprep for 3 days or another extend for another 2 weeks tu, what are the next plan?
Refer and then probably renal biopsy.
Okay lah, so renal biopsy, some steroid resistant also in the end up become minimal change disease also. It's also possible. Okay lah, FGS is still possible lah. Okay, so they have to go into the steroid resistant regime protocol lah. Okay, so usually do you know any steroid resistant regime they can use?
Steroid resistant regime. They will the induction dosage continue until you achieve remission.
They will have some past metaprep in certain thing lah. What are the treatment called? Remember? Don't remember. Okay. Don't know. Can't remember.
Can't recall at the moment. There's a name.
There's a name lah. That's what I'm asking. Okay, never mind. Later if you remember, you think lah. Okay, that's fine. So the new nephrotic syndrome protocol, any change in the new guideline, in the new nephrotic syndrome treatment?
New guideline. I've yet to read a new guideline. This year. I've yet to read the new guideline.
Okay. Don't know. Okay, never mind. So, what are the complications that we fear about in patient with nephrotic syndrome?
Definitely Cushing with the Cushing blood features.
Okay.
BP high, chronic infection.
So that hypertension can be what causes of the hypertension in nephrotic syndrome, especially patient haven't started induction yet.
Haven't started induction. Can be renal artery stenosis.
Can. Then
some secondary infection and then causing BP high.
Well, secondary causes lah, as you said earlier, it can be SLE, autoimmune, whatnot lah. Okay. Alright. So ada complication possible can happen?
Ada complication from nephrotic syndrome.
Why they prone to infection?
Because the albumin, intravascular depletion of the albumin.
Is it albumin?
Or the
Immunoglobulin lah per se. Because immunoglobulin are proteins, right? Okay, so they lost their immunoglobulin, so prone for infection. So what else do they lose? What protein do they lose also that can develop complication? Coagulopathy. Is it really coagulopathy? Yeah, what kind of coagulopathy? Is it bleeding type or thrombosis type?
Should be thrombosis type lah.
What do they lose? What factor? What?
Factor S
Okay.
Protein C
Protein S, apa lagi? What do they lose? Antithrombin 3, whatnot. All those things can increase the thrombosis punya risiko lah, because this thing counter the thrombosis punya processes. Okay. Alright. So if they have thrombosis, what two organ that can be affected? Two system that can be affected. Which organ?
Brain, the cavern sinus.
Okay, some more.
And mesenteric, the artery thrombosis.
Okay, so what else?
Renal artery.
Yeah, renal artery thrombosis lah. Sama ada dia develop kidney failure or gut ischemia and the stroke lah. Okay. I think the new changes in terms of a guideline for nephrotic syndrome is they're trying to reduce the burden of steroid. Okay. For example, patient yang frequent relapser, they always on the taper over 6 months.
Yeah.
Right. Okay. And then nowadays because the study shows that almost everyone nephrotic syndrome will have some relapse at certain point. Even they do frequent relapses pun, even whatever you do taper 6 months pun, they still relapse. So instead of giving the risk of steroid more over the course of 6 months, despite you tapering down at lower doses, so they just gonna stop it up to 2 months, 3 months macam tu je. So they will, doesn't matter lah you frequent relapser ke apa ke, they will probably stop it. Taper up to 3 months. So
set a time limit lah, rather than
because if they say it doesn't matter, they will relapse, we just treat the relapse until they So in the end, if they still frequent relapser, so they want to reduce the steroid burden, so your probably option to get the other option ada induction punya drugs like cyclophosphamide or levamisole. Okay. So what is the problem to start cyclophosphamide? How do you start cyclophosphamide for this frequent relapser? This is your decision. Don't even nephrotic. No, it's not if nephrologist punya decision. Cyclophosphamide is general pediatrician punya level of decision. You don't even have to inform nephrologist pun. Of course you can consult lah, but if you want to start, that's fine, because if you want to start some other drug like levamisole or cyclosporine ke apa ke, you probably need to consult. The one is probably their decision, but cyclophosphamide is not. But it's good to consult lah, because sometimes you're not familiar with. So what are basically the things that you need to check before starting cyclophosphamide?
FPC, looking at leukopenia.
Okay.
Then UFAM also lah, looking at hematuria.
Okay, that one you started, you monitor with the ABC lah, because the risk of leukopenia and then hemorrhagic cystitis. But before you start, what are the conditions that patient have to be in?
The patient has to be in remission.
Yes, of course they have to be in remission. When once they're in remission, straight away start cyclophosphamide lah. They cannot be started during the relapse punya part. Okay, so you will start, and then what are the before you start, so you have to counsel them. What you have to counsel? The risk for what?
Patient will likely be immunosuppressed.
Okay,
So
just
they
one. Some more?
Then the bleeding in the
Some
urine,
more? Bleeding, some more?
hair loss.
Some more? Hair loss, okay.
Mucositis.
Can, some more, but the dose is not as high as cyclophosphamide for other cancer. But there is one risk you have to mention. Apa dia? Especially I think probably in boys lah.
Infertility lah.
Yeah, in gonadal toxicity. Okay. I think the girls probably also same. I can't remember lah. But you have to counsel je lah. Okay. But sometimes there is not much option. They don't not keen. You can opt for levamisole. Levamisole is not really anti-cancer ke apa. It's just anti-helminth, which is your ubat cacing. Okay. Alright. Okay. Senangkan soalan.
What's the protocol again? I cannot remember. There's this patient, Mashika in IPA. Later I cari balik.
Yes, Mendoza regime. Okay, the name of the person who's probably the start the thing lah. It's a weekly, week 1, week 2, week 3, week berapa entah. Dan the mental prep pass, dan continue your steroid, whatnot. Okay lah, then you check your urine FME apa semua. And they should probably have remission lah, but some of them can only achieve partial remission. Okay.